Great. So, welcome everyone for the cardio colloquium here today. We thank you all for joining in on this busy week, and let's get straight to it. So before we begin, it's my honor and pleasure to introduce Dr. Tushar Roy as our moderator. Of course, sir doesn't require any introductions. Sir is DM, MRCP from UK, Eden as well, LLB, D-Card, FISC, and much more. Sir is a well-renowned faculty in most of our national and international congresses. Sir has also part of various clinical trials and has various publications under his name. So we welcome you here today, and over to you, Dr. Roy, as well. Apart from that, we have Dr. Sumit Bhatnagar. Sir is from Siddhanta Red Cross Hospital, Bhopal. Dr. Vivek Mathur, who's the Director of Interventional Cardiologist at Mittal Hospital, Ajmer. And finally, we have our expert, Dr. Arif Wahib as well. Sir is a Senior Consultant Interventional Cardiology at Indraprasth Apollo Hospital, New Delhi. With this, I give the floor to Dr. Tushar Roy. Over to you to discuss 30 years of air to ARS navigating RAS inhibitors in post-MI patients. Over to you, sir.
Thank you, Dr. Ronak. Today, good evening, friends. Today, we are going to have a little special meeting. You know, we all talk about heart failure with reduced ejection fraction, but today we are focusing only on one special aspect of heart failure with reduced ejection fraction, and that is post-myocardial infarction. So what are the details and what are the studies that have been done in this particular space? That is, after myocardial infarction, whether or not revascularization, that is PCI, has been done, and what is the role of RAS inhibitors in these situations? Next slide, please. So to look at this data, we will be looking at the three groups of molecules, that is the ARBs, the ARNIs, and the AC inhibitors in this particular space, that is post-myocardial infarction with reduced ejection fraction. And we'll be discussing all the trials that has been undertaken in this sphere. But right on, I would like to go straight to the summary, which I will again conclude at the end. And the summary is that it is safe to start ARB or ARNI or AC inhibitors within 24 hours of a myocardial infarction, whether or not revascularization has been done, provided the patient is stable, the systolic blood pressure is more than 100, and the blood creatinine is less than 2.5. That means the GFR is more than 30. So in these situations, it is quite safe to start. I will show that it is quite effective to start. And all the trials that have been done have started it in less than 24 hours to up to 10 days post-myocardial infarction. All the trials had an ejection fraction of either less than 40% or less than 35%. And we'll be talking about this. The summary is that AC inhibitors seem to have an edge over the ARBs and the ARNIs. And ARBs are similar to AC inhibitors, but they have a little bit of a safety profile problem, whereas AC inhibitors and ARNI are the same as far as myocardial infarction is concerned. Next slide, please. So straight off, we'll go into the ARB trials. Next slide, please. So there's been two ARB trials that has been done in 2002 and 2003, the Optimal and the Valiant trial. The Optimal trial was used losartan, and the Valiant trial used valsartan. In the Optimal trial, which was reported in 2002, more than 5,400 patients post-myocardial infarction was started on losartan, 50 milligram once daily, less than 10 days after sustaining a myocardial infarction. Ejection fraction was less than 35%. So losartan was actually compared to captopril, which was given in a dose of 50 milligrams 3 times a day. Here in this trial, the all-cause mortality was the similar. That means losartan and captopril, there was no difference as far as the all-cause mortality was concerned. But there was in cardiovascular mortality, although they were very much similar, but there was a slight trend of a worse outcome, slightly worse outcome, as far as losartan was concerned compared to captopril. In the Valiant trial published in 2003, more than 14,000 patients, again, valsartan was started in less than 10 days after myocardial infarction. Ejection fraction was less than 35%. The mean follow-up was a little more than 2 years, 24.7 months. Here, valsartan 160 milligrams twice daily was compared to captopril, 50 milligrams thrice daily. But there was also another wing where valsartan was compared to valsartan plus captopril. So there was a valsartan versus placebo, valsartan versus captopril, and valsartan versus valsartan and captopril in this trial. And it was found that the all-cause mortality, there was no difference in the all-cause mortality. Also, there was no cause in the secondary endpoint, which was cardiovascular mortality, heart failure hospitalization, or myocardial infarction. No change at all between the two regimes or the three regimes. The problem was that if valsartan was combined with captopril, there was a higher incidence of adverse drug reactions. So in summary, we can say that the ARBs and the AC inhibitors, in this case captopril, against the ARB, either losartan or valsartan, in a post-myocardial infarction have similar results, except that AC inhibitors, that is captopril in this particular case, had a slight edge as far as the side effect profile was concerned. Next slide, please. So here's the optimal trial, as I told you about, and I will go over it once more. So as I said, there was no significant difference in the all-cause mortality. And the cardiovascular mortality, there was a trend for losartan to be slightly worse than captopril. Next slide, please. And here's the Valiant trial. Again, as I said, that the all-cause mortality, there was no difference. Cardiovascular mortality, heart failure, hospitalization, and myocardial infarction, no difference. But there was an increase in adverse reaction if valsartan was combined with the captopril. So valsartan or captopril is good enough, but combination of the two does not seem to work too well. Next slide, please. Next slide. So we'll be talking about ARNI now. And there's only one trial in this ARNI sphere, and that is the Paradise MI trial. And that's the most latest trial that we have, published in 2021. Here, basically, ARNI, that is sacubitril valsartan, was titrated up to a maximum dose of 200 milligrams twice daily versus ramipril, which was titrated up to a dose of 5 milligrams twice daily. Used in patients of myocardial infarction less than 7 days with an ejection fraction less than 40%. The total number, next slide please, was more than 5,600 patients. The mean follow-up was approximately 2 years. And the primary endpoint was cardiovascular mortality, heart failure hospitalization, and worsening of heart failure. There was no difference. Although there was a tendency for RD to be slightly better, but when statistical analysis was done, there was really no difference between the two. And adverse drug reaction was also the same as far as the two are concerned, except for a couple of points. Next slide, please. So here's the trial data. If you can see that the HR, the hazard ratio, actually crosses unity. That is, the 95 confidence interval is between 7.78 to 1.04. It is crossing unity, and therefore this is not significant. So there is no difference either when if you use ARNI and ramipril. The only problem is that they had to uptitrate it 200 milligrams twice daily. But as we and I know, that it is very difficult really to upgrade ARNI to 200 milligrams twice daily in our patients. Whereas our experience generally is that it's very easy to uptitrate ramipril to 5 milligrams twice daily. And as you can see, there's no difference between the cardiovascular mortality, heart failure hospitalization, or worsening heart failure on an OPD basis, except for a couple of points. Next slide, please. And here's the ADR reaction. If you look carefully, you'll find that, so this was the same. Next slide, please. Yeah. So if you look carefully, you'll find that hypotension was a bit more in sacubitril valsartan, whereas cough was a bit more in ramipril. So 28% hypotension compared to 22% ARNI versus ramipril, whereas cough was 9% versus 13%. So that was the only difference between the two. Next slide, please. So in summary, then that's the only single trial that was done in a post-myocardial infarction heart failure reduced ejection fraction sphere. So in summary, we can say that sacubitril valsartan did not result in any significantly lower deaths or hospitalization. And the tolerability of both were the same, except for the two things that I mentioned. Hypotension a bit more in ARNI, and cough a bit more in ramipril. Next slide, please. And this is what was said, highlighted in so many, articles. Next slide, please. So now we go directly to the AC inhibitors. And AC inhibitors, next slide. So before we go into the AC inhibitors, I would like to say that most of the trials regarding AC inhibitors were done between 1992 and 1997. So there are no recent trials in this sphere, post-myocardial infarction, heart failure with reduced ejection fraction. But they were really, really large trials that I will come to. For example, the largest trial was the ISIS 4 trial published in 1994. Although the total number of patients there was more than 58,000, but the group that involved AC inhibitors, captopril in this case, was more than 19,000. Now, 19,000, more than 90,000 has never been done in any particular trial. Similarly, in 1994, there was a GC3 trial that was published. Overall, it was almost 19,000 patients, but they used lisinopril in this particular case, and lisinopril group was about 6,000. So much, much more than any of the other patients. So next slide, please. So here's the SAVE trial, as I said, 1992. The SAVE trial had more than 2,200 patients. It used captopril versus placebo. The main follow-up was about 3 years. The captopril was started within 3 to 16 days of myocardial infarction. Ejection fraction was less than 40%. As I said, captopril was compared to placebo. Here, the all-cause mortality was reduced by about 19%, and the myocardial infarction was reduced by about 25%. So that is the kind of data that we have with captopril in the SAVE trial published in 1992. Next slide, please. We have the one trial that uses this medicine called trandalapril, called the TRACE trial, published in 1995. And this was a trial that had more than 1,700 patients, 1,700 patients, where this particular molecule was started between 3 to 7 days of the onset of myocardial infarction. The mean follow-up was about 3 years. And when they compared it, they found that the all-cause mortality reduced by about 25%. Myocardial infarction was reduced by about 15%, and sudden cardiac death was also reduced by about 20%. So you can see that the trend is going more or less in the same direction. That means when AC inhibitor was used, any one of the AC inhibitors, there is a decrease in all-cause mortality, and there's a decrease in incidence of myocardial infarction, in heart failure hospitalization, and even in sudden cardiac death. Next slide, please. Yeah. So we'll come to the other trials that was done in this particular sphere. And as I said, we'll go by the years they were published. So in 1994 was published the GC3 trial. Now this GC3 trial had overall almost 19,000 patients. So in this case, lisinopril was used. It started within 24 hours of the myocardial infarction if the patient was stable. But there were other groups also. For example, they had a group in which they used glycerin trinitrate as a transdermal patch. And of course, there was a placebo group also. So as far as the GTN was concerned, it didn't make any difference. There was no significant difference. So GTN transdermal is no longer used in myocardial infarction. But in lisinopril, there was a significant benefit. And in this subgroup, there was more than 6,000 patients. 6,000 patients. The all-cause mortality was reduced by about 12%. So again, similar trend as you can see. There's a significant reduction in all-cause and, of course, cardiovascular mortality. The trial that was published in 1995 was the ISIS-4 trial, one of the largest trials in cardiology, more than 58,000 patients, but they had several wings, several branches. And the one that used captopril compared to placebo, one used isosorbide mononitrate against placebo, and the other used intravenous magnesium versus placebo. This was an open label trial. Sorry, intravenous magnesium versus open label. So it was an open label trial. But why magnesium? You know, when I was an associate professor in Safdarjung Hospital way back in 93, 94, we used to use a lot of intravenous magnesium in patients of acute myocardial infarction. The reason was that lots of small trials had shown that giving intravenous magnesium in patients with acute myocardial infarction was hugely beneficial. In fact, the mortality reduction was tremendous. In fact, however, there came a trial called the Limit 2 trial, I remember, and this ISIS-4 trial that actually showed that giving intravenous magnesium was not of much use. And since then, we've stopped using intravenous magnesium, except in patients with ventricular ectopics or hypomagnesemia, a post-myocardial infarction. So that was the trial, ISIS-4 trial, more than 58,000 patients. But the wing that had captopril versus placebo was about 50 milligrams. Was about more than 90,000 patients, in which 50 milligrams twice daily of captopril was compared to placebo. And here again, it showed that there was a significant reduction in all-cause mortality and heart failure hospitalization, ISI-4. The other trial in the same sphere was the Chinese trial, that is the Chinese captopril study 1, published in 1997. This was the latest, in the group of trials. More than almost 15,000 patients where the captopril was started in a mean period of 16 hours after a myocardial infarction. And the mean follow-up, of course, was a 4-week period where captopril was compared to placebo. Starting was at 6.25 milligram twice daily, went up to 12.5 milligram twice daily. There was no difference in the all-cause mortality, but there was a significant difference in reduction of heart failure in patients in which captopril was used. Next slide, please. So you can see the large number of studies, patients have been tested with AC inhibitors in this particular case. And now we come to a very, very interesting trial called the AIRI study, which was first published in 1993. Now, Erie is actually a name of a river. In fact, I was in Leeds in UK, and the river Aire, as they say, it flows through that city. I used to work at Leeds General Infirmary, and we wouldn't call it a river. I mean, not in Bengal, not in Bangladesh. We wouldn't call it a river. It's a very, very small thing where long, narrow boats fly down the river. I used to walk around the banks so many times. So that was the name given to this particular trial, the AIRI trial, that was first published in 1993. Had more than 2,000 patients. The drug used was ramipril, used within 3 to 10 days of the myocardial infarction with a reduced ejection fraction. And ramipril was either given in a dose of 2.5 milligrams twice daily or uptitrated to 5 milligrams twice daily. The follow-up was a very short period of follow-up, about 15-month follow-up, but the all-cause mortality was reduced by about 27%, and the myocardial infarction and strokes were also reduced by about 19%. And the benefit it was seen was started within 30 days of starting the ramipril. So that was the benefit was seen very early in this particular group. But the interesting thing about this trial, compared to the other trial, was that it had a very, very long follow-up. So we had an extension of this called the AIRI-X trial, where the follow-up was for about 5 years. And there also it showed there was a significant difference, but I'll skip that to go to the largest follow-up of ramipril that was done. And that was in 603 patients. So we know the original was more than 2,000 patients, 2,006 patients. The follow-up was for 603 patients. This was published in 2021. The AIRI-S trial, that is the further extended trial. And the follow-up was anything between 28 to 30 years. That's right, 28 to 30 years of follow-up. That's a huge follow-up. I mean, I don't remember any other study that had such a long follow-up. And the median survival was improved with patients who had used ramipril. It was improved by about 14.5 months. Next slide, please. So that's the amount of study. So we'll go through this thing once more. So median survival was 8.3 years in placebo and 9.6 years in the ramipril group. Estimation extension of life was 14.5 months, a huge increase in survival. And the survival crosses at 14 years from time of randomization and so on. So next slide, please. Yeah, so here is a study, and we'll not get into the nitty-gritty of this, so many numbers that we see on this slide. Suffice it to say that the worst is the condition of the patient, the better is the outcome if ramipril is used. So if the patient has diabetes, it has got a much better outcome if ramipril is used than if he does not have diabetes. If he has a previous MI, again, better outcome. If he has a past history of heart failure, better outcome. Hypertension, better outcome. Angina, better outcome. And if he's, elderly, then of course a better outcome. So the worse is the condition of the patient, the better is the outcome, not worse. Better is the outcome if ramipril is used. Next slide, please. So in summary, we can say that there is a substantial survival gains with ramipril treatment, even up to when it is used for more than 15 years or beyond, because it was used for almost 28 to 30 years in patients, the IRA subgroup of patients, 600 patients, follow up for almost 28 to 30 years. Overall, there is a significant improvement in survival, and the total survival has been improved by about 14.5 months if ramipril was used post-myocardial infarction. Next slide, please. And we can see that the worse is the outcome. Next slide. Worse is the outcome. The worse is the morbidity of the patient, the better is the outcome if ramipril is used. So patients with diabetes, previous myocardial infarction, previous heart failure, hypertension, angina, the improvement was there and even better than when Ramipril was not used in this particular case. Next slide, please. So in conclusion, we can see that Ramipril treatment for even for a year or more, when started early post-market infarction, as I said, that it can be started very safely, even in less than 24 hours, whether the patient underwent a PCI or not, provided the patient was stable, the systolic blood pressure was more than 100, and the creatinine was less than 2.5. So, and I've shown you conclusively, I believe, that long-term use of Ramipril, even up to several years, definitely prolongs the life of the patient. Next slide, please. So what are the current guidelines? Next slide. So the current guidelines say this similarly, that early initiation of RAS inhibitors is beneficial in patients who have a reduced ejection fraction post-myocardial infarction, no doubt about that. And I've just showed you data that we have two trials with ARB, losartan and valsartan. They were similar to AC inhibitor captopril when compared to captopril, with a slight edge of captopril had over ARB. We had the ARNI trial, only single trial, compared it to Ramipril, where they were very, very similar, except for the fact that I believe that Ramipril 5 milligram twice a day is far easily reachable than 200 milligram twice a day, as was done in that particular trial. Next slide, please. So here's the ESC, next slide. So here's the ESC guideline on the management, and it says 2020 guidelines, management of acute coronary syndromes with. So we say that AC inhibitors or ARBs in case of intolerance or intolerance to AC inhibitors are recommended in patients with heart failure with reduced ejection fraction, diabetes, chronic kidney disease, unless contraindicated, in order to reduce all-cause mortality and cardiovascular mortality. And that's exactly what we've been saying in this particular talk. Next slide, please. So I'd like to ask my colleagues the following questions. A question to Dr. Sumit Bhatnagar. In post-myocardial infarction patients post-revascularization, at what systolic blood pressure do you initiate ACE inhibitor therapy? What is the starting dose do you recommend, and how do you titrate the dose? To paraphrase that, I would like to say that, so at what systolic blood pressure do you not start ACE inhibitors? How do you start? Which ACE inhibitors do you use? Or do you prefer any other RAS inhibitor? Which one do you use, and how do you up-titrate the dose? Dr. Bhatnagar, please.
Yeah, thank you, sir. Thank you, sir. Generally, what I start, sir, I keep it, my threshold is very low. Till 90, I am very comfortable. Even if patient is having a BP of 110, I start on low dose of Ramipril, 2.5 milligram. Generally, I started with OD dose, and then however the patient tolerates, then I started upgrading to 2.5 mg BD before discharge. I try to give it 2.5 mg BD. And then on follow-up, then I try to increase the dose of ACE inhibitors, Ramipril. So definitely in post-MI patient, only ACE inhibitor which is indicated definitely is Ramipril. There is no other medication which we don't have data to foresay that. Generally, it is the only Ramipril which is indicated. And generally, my starting dose is definitely when the patient who have came with acute MI, they are having a low BP. If the patient is if the BP is less than 90, I preferably do not give ACE inhibitors. I try to keep it monitoring. Once the patient gets stable, shock improves, then I started with the low dose of Ramipril.
Excellent. So Dr. Bhatnagar is of the view that he's not afraid to, if the patient is stable, he's not afraid to start Ramipril even when the systolic blood pressure is hovering around 90, provided the patient is otherwise stable. And he usually starts with a dose of 2.5 milligram once daily and tries to titrate it up to 2.5 milligram twice daily before he discharges the patient, and up-titrates it to 5 milligram twice daily on the OPD follow-up. So thank you very much, Dr. Bhatnagar. And then I would like to ask Dr. Arif. Dr. Arif, will you switch the patient to an AC inhibitor if the patient at the time of MI was receiving ARB for hypertension? For example, the patient comes to you as a known hypertensive, is on an ARB. Would you like, and post-myocardial infarction, low ejection fraction, patient otherwise stable, would you continue on the ARB or would you like to switch over to AC inhibitor?
So as we all know that the main, the advantage and the trials, they show a beneficial effect of AC inhibitor in post-MI. ARBs are to be used when there is a side effect or you are not able to use AC inhibitors. So the primary choice should be an AC inhibitor. But if the patient is taking an ARB and is not having any reduced ejection fraction, not having any side effects, then I think we can prefer to continue with an ARB. But if there is an LV dysfunction or the patient is in heart failure, then obviously the choice should be an ACE inhibitor, and we should be shifting to an ACE inhibitor.
Excellent. Thank you. I am in total agreement, Dr. Arif, with what you said. And you essentially said that if there is low ejection fraction, no heart failure, then it's quite okay to continue with the ARB. But if there is a reduced ejection fraction, you would like to shift the patient from ARB to toward ACE inhibitors. Yeah. Thank you. I'm totally agreement with them. I think all the panelists will agree with this. Next, may I ask Dr. Vivek Mathur, how early do you think it is safe to start an ARNI if you want to start an ARNI in a patient post-Merkel infarction?
Well, really, and post-MI patients with severe LV dysfunction and having any sort of, the patients are on any inotropes or any sort of escalation of diuretics, and all these things first should be ruled out before starting an ARNI. I think once the patient has stabilized, best time is after 24 to 48 hours, having the patient stabilized by revascularization or anything. It's 24 hours, that is the day 2, I would rather say. And at that time, you can start with a very low doses of RD. You start them, and by the time you're able to discharge the patient, so I think we're not in a hurry to give full doses or the rapid escalation of the doses. But I think 24, 48 hours, once the patient has stabilized, any hemodynamic stability is achieved, then after we can start with an ARNI. Although the trial has shown no additional benefit of just after post MI as compared to ACE inhibitor. So, but still the patient who have LV dysfunction, and the further different trials have shown that ARNI is of better benefit for these LV dysfunction patients in the next coming weeks. So it's better for the patient to be started on ARNI after 24 to 48 hours once they have stabilized and they are on the other drugs also, for example, the beta blocker and all.
Thank you, Dr. Mathur. I think we are totally in agreement with you that if the patient is stable, it's absolutely okay and safe to start ARNI 24 hours if the patient is stable. Starting with a small dose, there's no hurry to increase the dose, and in the either pre-discharge or after discharge, we can go to the optimal dose of ARNI. Thank you very much. And now I would like to ask Dr. Sumit Bhatnagar, post revascularization, if there is LV dysfunction, but the patient is not in clinical heart failure, would you still like to add RAS inhibitors? And if you want to add RAS inhibitors, would you like to add an ACE inhibitor or an ARNI?
So, sir, post revascularization, if I find that the patient is having LV dysfunction, reduced ejection fraction, definitely the choice can be both the things. The patient needs to be on RAS inhibition. That is one thing is very sure. For not only point of view of just reduction, it's basically the multiple benefits of RAS inhibition, like it reduces the fibrotic and of fibrosis and all those things. Definitely, so it is indicated that if patient's EF is less, definitely RAS inhibition is one thing which is very much required. So, and now coming to the choice, so definitely there are two things which we really need to think about in India is the cost. So when we talk about that thing, and we know that about ARNI is definitely whatever, even if it has become cheaper, it is not at comparison to ACE inhibitors. And if patient is not able to buy medication, buy cheaper medication, and he wants some medication which is lower at which, so something is better than nothing, what I will say. ARNI can be a preference if given to me, but if not, patient is not tolerating, or if patient is, if I feel that compliance will be poor because of the cost and all those issues, definitely ACE inhibitors will be my choice. And if I feel like that patient definitely at a starting point, somehow patient is already taking ACE inhibitor, I'm not directly going to switch it. If I feel that patient is already taking and he's doing good with all these things, and if I found that patient is having second, but if he's very much comfortable with that, so I might continue with that thing. I don't want to change the patient to something else because patient is stabilized at that part.
Thank you, Dr. Sumit. I think that was a wonderful answer to the question. Next slide, please. So, I would like to ask these questions. Of course, any of the panelists can chip in. but these would be directed to certain. So, Dr. Arif, the first question: when would you like to start a beta blocker in this particular case, that is post-marital infarction, reduced ejection fraction? Which beta blocker would you like to start, Dr. Arif?
Yeah, so in post-revascularization, the ideal thing should be to start as early as possible, unless until there is a contraindication. If the patient is in heart failure or is showing an AV block, then you wait for it for things to settle down. And the preferable choice should be, what I prefer, should be uh, because the hemodynamics are such that the patient initially, though the data is for an extended release metoprolol, I would prefer to start with a short acting metoprolol, and if the patient is tolerating it, then I switch it over to an extended release metoprolol.
Thank you, Dr. Vivek. Which is your preferred beta blocker? Because we know we have carvedilol, we have metoprolol, we have bisoprolol, and even we have nebivolol, which has all been shown to be beneficial in these patients. Which is your particular choice of beta blocker, and why?
So, as rightly said by Dr. Arif, the choice of drug usually most of after post revascularization is usually metoprolol started with. But definitely, if the patient have congestive heart failure and they are post revascularization into the long term follow up after 7 days or 14 days, choice usually I change them to bisoprolol because of the evidence available with the bisoprolol and the drug. So usually I keep them on bisoprolol normally patients, and some of the patients who require where the blood pressure is not available. I mean, the blood pressures are on higher side also. So carvedilol has an additional ability to decrease the blood pressure also. So carvedilol is also the choice of drug in such patients also. And of course, these three agents have shown their ability to improve the prognosis in these patients with congestive heart failure and the MI patients with LV dysfunction. So I think metoprolol, bisoprolol, and carvedilol are my choice of drug.
Right. So, Dr. Sumit, what dose would you initiate the beta blocker, and what is your preferred way of up-titrating the dose?
Sir, about beta blocker, definitely I would start with if you ask me, the preferred drug of choice is maximum time is bisoprolol because of the CIBIS trial and all this data we are having with in post-MI patients. So definitely I try to go with bisoprolol, and that is my 2.5 is the initial dose. But when as I said, that is the most important thing which I have to think about when we are taking a Indian patient. So you have to think about the compliance and the cost. So when you think about that, then definitely the metoprolol and the ramipril combination, which I say to reduce the pill burden and to reduce these, what I say, the cost of the medication. Then in these patients, when you have to give as many as less more medication with the maximum benefit what you can give. So in that cases, I generally prefer a ramipril and metoprolol combination, which can be given, and that's how I generally start, and that is to be started as early as possible. Definitely that is one thing. We have a data to start in 24 hours. We can start ramipril, and then maybe after that we can start a beta blocker if patient is not in heart failure. So we can start a combination. Even on discharge also we can give a combination so as to reduce the pill burden, because that is the biggest challenge which I think as a doctor we feel when the patient comes and asks, sir, the number of dawaiyan kam kar do. So definitely the combination, and we generally have a combination right now of ramipril with metoprolol only. As of now, we don't have a combination with other molecules, other beta blockers.
That's right. So you see, so we've seen that AC inhibitors are useful. We've just seen all of you say that beta blockers are very useful in this particular group of patients. And Dr. Sumit just said that we can combine the two. So I have this question for Dr. Arif, that we can now combine AC inhibitors and beta blockers, of course. So when would you not like to start the two as a combination, and what would you be cautious about when you're using this particular combination?
So ideally, I should be when I'm what I prefer is that when I start with these drugs, it is better to start them as an individual drugs, then see their response at what dose the patient is tolerating, and then you combine it at the maximum tolerated dose. But the thing is, when you are combining both the drugs, there would be a exaggerated hypotensive response, because both the drugs you are giving at the same time. So hypotension is a factor, definitely, and the difficulty is that you cannot modify the drug dosage. So unless until you have a stable level of this drug for quite a long time, giving a combination becomes a very tricky question. So ideally, I would combine it when the patient is taking both the beta blocker and the ACE inhibitor for a long time. He is compliant with the drugs and is tolerating it well. Then I would think about combining. At the initial time or at the post MI, at the post revascularization stage, I don't prefer to combine it at that stage.
Thank you. I think, yes, I think I totally agree with you. And so my last question to Dr. Vivek is that supposing the patient is on ACE inhibitors, do you think you would like to shift over to ARNI, or would you like to continue with ACE inhibitors in this particular case?
So the patient, if is already on ACE inhibitor, suffered in myocardial infarction and having a low LVEF, continuing, since we don't have any very robust data for acute MI patients, I would rather not change the drug to, from ACE inhibitor to ARNI. But in the following weeks, definitely, since the data is already available for such patients, I would rather like to shift them from ACE inhibitor to ARNI, but not in the acute setting. There is no additional advantage that you get while shifting. But in naive patients, definitely after having the clue that the patient has stabilized, then I would start the patient on ARNI rather than ACE inhibitor.
Thank you. So now these questions are for all panelists. I will just, from the next slide, please. I would just like to formulate this question. We have all agreed that RAS inhibitor should be used in this particular group of patients, that is post-myocardial infarction, whether or not revascularization has been done, ejection fraction less than 40%, whether or not they have symptoms of heart failure. We have also established that that ACE inhibitors and ARNI might be slightly superior to ARB in this particular case. But right now we are, I think, in two camps as to whether ACE inhibitors is to be started or ARNI is to be started, and when should one start the one and when should one start the other. So is there any particular clinical symptom, sign, or even a biomarker like NT-proBNP that helps you actually to decide that in this particular case, I would use an ACE inhibitor, or that particular case, I would use an ARNI? This is open to all panelists. Please go ahead.
Sir, I don't think so that there is any specific marker for this thing, because as per the trials, I don't think so. I don't remember is there any trial to say that which is to be preferred over which one. Now, definitely ARNI is making a promising results, and then definitely we are having a good data with ARNI also, and being using it regularly, so we are seeing the changes of LV remodeling. So if you ask me, then definitely deciding marker is to me is only how much the patient is going hypotensive, because with ARNI I have seen more of patients those who are going hypotensive. That is one thing, which is one thing. And renal dysfunction and creatinine eGFR, I think so maybe that it can be a deciding factor, but not very much to me in any specific things which decides over one another. I would definitely, because looking at the benefits of ARNI and the trial we are having, then definitely ARNI holds superior in some of the aspects.
Thank you. Any other comments?
I think, sir, the clinical judgment is the best guide to go what to do with the patient. So the modification of therapy, depending upon your clinical judgment, is the preferable, especially if we consider the cost and everything that goes into doing an investigation. But if the patient is affordable and you have a doubt, then we can do an NT-proBNP, decide that yes, this is a preferable agent. But this would be a very small substrate of patients, because generally if the patient is coming with an MI and you think he has a heart failure, NT-proBNP will definitely would be elevated.
Right. Thank you very much. And now the last question of the session, and this is to all the panelists. And this has got nothing to do with the topic that we've been discussing. So it's got nothing to do with the post heart failure. So it's just post acute coronary syndrome. So with or without heart failure. Of course, with heart failure, we'll definitely use, but supposing there is no heart failure, would you still, after revascularization post ACS, use an AC inhibitor in these patients? Dr. Arif, Dr. Vivek, Dr. Sumit?
Well, we all know that these patients, for example, the post-MI patients, then these patients have some sort of, the excess of, renin-angiotensin system is quite activated in all these patients. So theoretically, all these patients require some sort of a, beta blockade, sympathetic, blockade, and the RAS inhibition blockade. And we know that having added these agents to these patients definitely translates into good prognosis as such. But clinically, when you look to patients, sometimes we are guided by, the ejection fraction, the stability of the patients, the heart rate of the patients. For example, a patient coming with heart rate of 60 would rather not like to add at that time the beta blocker, but you know that this patient has got the benefit of it. One is the clinical judgment that I would say, but definitely these patients, if their blood pressures and the clinical scenario allows, then definitely adding an ACE inhibitor to post-MI patients and a beta blocker to these patients definitely improves their prognosis. Starting dose are guided by their hemodynamics, and the further that you go into the clinical phase of these patients, then you decide whether to how much to increase the dose, what dose you can go up to. But all these patients definitely derive benefit of adding an ACE inhibitor and a beta blocker to post-MI scenario. Most of them, I wouldn't say all of them, but some, most of these patients rather.
Thank you.
I would like to say, sir, about ACE inhibitors and about any RAS inhibition. If patient is having an ACS, RAS inhibition is must, because it is having multiple benefits. Not only decreasing the hypotension, not only reducing the preload and all these things afterload, but it has multiple benefits that it reduces the fibrosis. It have multiple benefits in healing mechanism, also in LV remodeling also. So definitely all patients of ACS, whether we are doing any revascularization or not, but definitely RAS inhibition is a form we take it, but it has to be done. It has to be given to all the patients those who are having an acute coronary syndrome.
True. So if I can wrap up this excellent panel discussion. So although evidence-based medicines guides our thinking process, I think in the final say it's our clinical judgment that actually decides when to use which medicine in which patient, keeping in mind the clinical condition of the patient and his comorbidities. So thank you very much, Dr. Arif, Dr. Vivek, Dr. Sumit, and I hand over to Dr. Raunak of MCure.
Thank you, sir. Thank you, sir.
Dr. Raunak, you are on mute.
Thank you so much, everyone, for the wonderful discussion. It was quite insightful to hear from all of you. And I'm sure the audience has also learned something new today. So we have a few questions in the chat box. So one of the things was, sir, when you were explaining, Dr. Roy, regarding Arni and Ramipril, especially in the Paradise MI trial, that time the dose is very important. So in your clinical practice, how many % of your patients get elevated to 200 mg of Arni dose, and how many to 5 mg BD of Ramipril?
Yeah, so I in fact mentioned this in my talk. So I think most of our clinical experience is that very few percentage of our patients we are actually able to titrate up to 200 milligram twice daily. Perhaps 5%, perhaps 10%. I don't know. It may vary from practice to practice. But I don't think most of us are able to go beyond 100 milligram twice daily as far as Arni is concerned. Whereas I think most of us are able to go to 5 milligram twice daily as far as Ramipril is concerned. There is another thing I think which Dr. Sumit also brought out, that the cost factor is very important in our management, especially because such patients are on multiple medications. There are pill counters also. Cost is also important. So again, cost-wise also, I think Ramipril scores over that. And we saw in the Paradise MI trial that there wasn't too much difference between the two. So I think we can use our clinical judgment, keep the patient in front of us, as was the final decision taken by all the panelists, and decide whether we want to use either ACE inhibitor or ARNI in this particular case. If the patient can afford an ARNI, I think maybe ARNI can be used in this situation, keeping in mind that we may not be able to go to the 200 milligram twice daily, which has been prescribed in the trials. Keeping that in mind, one can make one's clinical judgment and choice whether to use ACE inhibitors or ARNI.
Right. Right, sir. Another question that we have in the chat box is regarding when cough is happening in ACE inhibitors, it means that bradykinin is increasing in the body, which might have supporting evidence for beneficial effects on the body. So, sir, what do you think about this? Maybe Dr. Bharadwaj can answer.
Any of that.
Bradykinin is increasing, but there is no data to say that this correlates with an improved mortality or the cough correlates with improved mortality. So the overall is, though the theoretical concept is okay, it doesn't translate into a clinical evidence. So no doubt the bradykinin is improving, but overall context is that it doesn't translates into improved mortality, and because you are not maybe because the person might, if you are saying the patient to take the drugs in spite of having cough, he might lose confidence in your treatment. So he may not take any treatment at all. So the thing is, it doesn't gives any beneficial effect in the whole context.
Okay.
Yeah. So yeah, I think that's fine. You see, I mean, I don't think there's any correlation between cough and increase in or decrease in mortality, or between bradycardia and increase and decrease mortality, which the doctor has just now highlighted. So I think we should take care of the cough, lest the patient leaves the medicine altogether. And here, in my understanding, the Ramipril, or ACE inhibitors has the worst percentage of cough, followed by ARNI, which contains valsartan, and followed by any other ARB. So we can, kind of step down and even go down to ARNI, because as we know, there's not much, very little difference between the two. So maybe ARNI can be given where cough is a major problem.
Yeah, you need to shift, and you have a hit and trial basis depending upon which gives you the least amount of cough. So you have to shift the drug and modify the treatment according to the side effect of the medications.
Right, sir. Right. Surendra, are there any other questions?
No, I think no further questions.
Okay, great. So, sir, with your permission, then we can conclude today's talk. So, thank you so much, Dr. Tushar Roy, Dr. Sumit Bhatnagar, and Dr. Vivek Mathur, and Dr. Arif for this wonderful discussion. And we hope that everybody has learned something new today as well, and that this might have helped in your clinical practice going ahead. So, thank you so much, everyone, for joining in for this evening.
Thank you. Thank you.
Okay. Thank you, Dr.
Thank you very much, sir.